Hello, my name is Vivian Haggerty, and I am a third-year medical student at Florida Atlantic University Charles E. Schmidt College of Medicine. My presentation today is titled, A Challenging Case of Twin Pregnancy with Complete Hydatidiform Mole and Normal Live Fetus. Complete hydatidiform mole with coexisting viable fetus, or CHM-CF, occurs in 1 per 20,000 to 100,000 pregnancies. Carrying a complete molar pregnancy to term has inherent risks secondary to elevated human chorionic gonadotrophin, or HCG, levels. These include hyperemesis gravidarum, preeclampsia, thyrotoxicosis, and possible preterm delivery. 34% of CHM-CF patients in a meta-analysis of 244 cases were diagnosed with gestational trophoblastic neoplasia. The live birth rate was 50%, and the rate of intrauterine fetal demise was 40%. In this case study, we examined the hospital course and obstetric outcomes of a patient with CHM-CF whose pregnancy was also complicated by past medical history of systemic lupus erythematosus and right kidney isograft secondary to end-stage renal disease. Among lupus pregnancy cohorts, the rate of preeclampsia ranges from 13 to 35%. This predisposition, combined with her molar pregnancy, led to development of preeclampsia with severe features. CHM-CF has been discussed in the literature. However, the expectant management of a patient with extensive comorbidities, including lupus and a right kidney isograft, with CHM-CF thus far has not been recorded. A 31-year-old woman, gravida 1, para 0, with past medical history of lupus diagnosed at age 16 and a right kidney isograft from her twin sister secondary to end-stage renal disease, presented to the outpatient clinic for initial prenatal visit at 8 weeks, 4 days gestation by last menstrual period. Ultrasound for dating at this visit showed a single intrauterine pregnancy with a complex focus adjacent to the gestational sac, measuring 3.8 by 3.1 by 5.4 centimeters of unknown etiology. At 16 weeks and 4 days gestation, ultrasound showed a prominent intrauterine fundal heterogeneous hydropic-like area, along with a viable intrauterine pregnancy, suggesting CHM-CF as the diagnosis. An MRI showing a fundal lesion with grape clusters, shown in Figure 1, findings consistent with CHM-CF, confirmed the diagnosis. The patient was referred to perinatology, and after extensive counseling, she declined both amniocentesis and termination of the pregnancy. Daily aspirin at 81 milligrams PO was started at this time. At 16 weeks and 6 days gestation, HCG levels were 313,074 milli-IUs per milliliter, compared to the normal 16-week gestational range of 7,512 to 132,084. Chest X-ray performed at this time was negative for metastatic disease. Serial HCGs reached 629,362 milli-IUs per milliliter by 24 weeks and 1 day gestation. At 27 weeks, 5 days gestation, the patient was admitted to the antepartum unit for inpatient workup to rule out chronic hypertension exacerbation versus superimposed preeclampsia after her blood pressure was elevated above baseline at a clinic visit. Her blood pressure responded well to IV antihypertensives. Her initial blood pressure on admission was in the 160s systolic and 70s to 90s diastolic. Her total 24-hour urine protein was 672 milligrams. She began oral antihypertensives. Blood work on admission revealed hyperthyroidism with TSH under 0.005, free T4 levels of 2.33 nanograms per deciliter, and T3 levels of 6.09 nanograms per deciliter. She was started on methimazole at this time. Gynecologic, oncology, maternal fetal medicine, transplant surgery, endocrinology, and nephrology were consulted and followed the patient throughout her hospital stay. She completed antenatal corticosteroids in preparation for a preterm delivery. Inpatient management was recommended until delivery at 34 weeks by primary cesarean section or earlier for maternal fetal indications. After counseling with transplant surgeons and obstetricians, the patient desired sterilization at the time of delivery for optimal immunosuppressant medications contraindicated in pregnancy in order to maximize isograft function. HCG levels reached a high of 685,290 milli-IUs per milliliter at 30 weeks, 1-day gestation. At 30 weeks and 5 days gestation, the patient had rising blood pressures at 160 systolic over 110 diastolic, unresponsive to IV antihypertensive medications. As a result, and without delay, the decision was made to proceed with delivery. Primary low transverse C-section with fan and seal incision with bilateral salpingectomy was performed, with transplant surgery assisting to avoid transplanted urethral or kidney damage. If hysterectomy were indicated, preparations were in place. An infant weighing 1,559 grams with APGARs of 4 at 1 minute and 7 at 5 minutes was delivered. The twin B sac with hydrops was delivered total en bloc with twin A placenta and sac as seen in figure 2. The uterus was cleared of all clots and remaining debris, and the incision was closed with a 2-layer closure. Estimated blood loss was 618 milliliters, and blood transfusion was not required. Postpartum course was uncomplicated. Magnesium was continued for 24 hours postoperatively. Blood pressures were well controlled, 120 systolic over 60s diastolic. The patient was advised to follow up with numerous practitioners to assess for risk of lupus flare postpartum, continued hyperthyroidism, worsening renal function, and cardiovascular disease. HCG was rechecked 2 days postpartum and had decreased to 80,518 milli-IUs per milliliter. The neonate continues to thrive in the NICU and is currently breathing on room air and tolerating feeds. Hydatidiform mole, also referred to as molar pregnancy, includes a spectrum of diseases that originate in the placenta and are classified as gestational trophoblastic disease, or GTD. These groups of diseases deserve special attention because, although benign, they have the potential to progress, locally invade the uterus, and metastasize. The incidence of hydatidiform mole demonstrates regional variance, with the widest range occurring in Latin America, Asian, and Middle Eastern nations, whereas North American and European countries report a smaller range, with low and intermediate rates. Of particular interest is the occurrence of a twin pregnancy consisting of one fetus and a complete mole. This rare obstetric phenomenon was first described in 1914 and has an estimated incidence that varies widely between 1 per 20,000 to 100,000 pregnancies. Molar pregnancies arise as a result of abnormal fertilization. Partial moles contain a triploid set of chromosomes and are the result of dispermatic fertilization of a haploid oocyte. On the other hand, complete moles consist of 46 paternal chromosomes and do not have any fetal structures. This distinction is crucial because if hydatidiform mole is associated with a viable fetus, as in our case, the normal co-twin of a complete mole has a better survival rate compared to the partial mole. CHMCF, although rare, has the potential to be faced with serious maternal complications such as spontaneous abortion, hemorrhage, hyperemesis gravidarum, preeclampsia, hyperthyroidism, trophoblastic embolization, and gestational trophoblastic neoplasia, as well as fetal complications, including preterm delivery and fetal death. Our case is unique in that we faced several of these complications in the midst of an already medically complex obstetric patient. This case outlines the obstetrical management of complications unique to this entity and also highlights the importance of a multidisciplinary team, which led to a successful delivery. Pregnancy in a kidney transplant recipient is challenging and carries inherent risks of maternal and fetal complications. 21.5% of pregnant kidney transplant recipients develop preeclampsia, compared to 3.8% of the general population. The rate of preterm birth is 43.1%, with a neonatal mortality of 3.8%. Our patient required expert consultation with an endocrinology team to mitigate the risks of hyperthyroidism. HCG is a glycoprotein hormone composed of a common alpha subunit and a hormone-specific beta subunit. It shares the same alpha subunit and a significant amino acid sequence in the beta subunit with TSH and interacts with the TSH receptor with a potency of 1/4000th that of TSH. This interaction reaches clinical significance if HCG levels remain elevated over 200,000 for several weeks. HCG levels in normal pregnancy may reach peaks of 200 to 300,000 between weeks 9 and 11 of gestation before declining. However, molar pregnancies are associated with elevated levels of HCG, often between 100 to 500,000, that continue to increase with increasing tumor mass. Concerningly, uncontrolled gestational trophoblastic hyperthyroidism may lead to life-threatening thyroid storm in affected patients undergoing surgery and anesthesia. Surgical evacuation of the molar pregnancy remains the mainstay of treatment and is expected to resolve elevated thyroid hormone levels. However, great care must be taken to normalize thyroid levels prior to any surgical intervention. Our patient reached a peak HCG level of 685,290 milliIUs per milliliter. Despite this significant elevation, our patient remained clinically euthyroid with only mildly elevated free T3 and free T4 levels due to management with methimazole. The lowest effective dose was administered to prevent fetal goiter or fetal hypothyroidism in the normal twin. Upon delivery, the baby was found to be biochemically euthyroid and has remained so on follow-up visits, emphasizing the importance of strict control of maternal thyroid hormone levels. The risk of gestational trophoblastic neoplasia is the most feared complication in these patients. A study by Seabra et al. Found a similar rate of gestational trophoblastic neoplasia between simple hydatidiform moles, 16%, and hydatidiform moles associated with a twin pregnancy, 19%. Our patient recovered from surgery and entered the post-molar follow-up with weekly serum beta-HCG measurements. Fortunately, she has already demonstrated downtrending serum beta-HCG levels, and we do not anticipate progression to invasive disease. In conclusion, we report a case of MRI-diagnosed CHMCF, further complicated by extensive maternal comorbidity with successful maternal and fetal outcomes. We hope to highlight the potential for a successful pregnancy with early admission for blood pressure control and meticulous monitoring of HCG levels, thyroid function, and renal function in the setting of CHMCF complicated by preeclampsia superimposed on existing renal disease. Inpatient workup of blood pressures elevated over the patient's baseline and close observation of renal function and immunosuppressants were essential to the success of this case. Thank you for your attention.